contrast when you can't really tell whether the vent is pushed or is invaded by the pus, and you don't see the pus in the region of foramen of Monroe. And abscess should, following the appropriate treatment, should completely disappear with only slight meiosis remaining in the region of the lesion, and that's eventually differentiated from other possibilities of a ring-enhancing lesion. So sometimes we have the problem of differentiating an abscess from a necrotic tumor, and as I show you, you might have a patient with metastatic disease and you see a new ring-enhancing lesion, but you're not always sure that this is a metastasis and not an abscess. So if you try to differentiate between the two, there is no 100% tool for imaging-based differentiation. And why is it important to differentiate? Because the surgical plan is completely different. In an abscess, you want to drain it, you don't need a surgery, just create a hole and aspirate the content. And in a tumor, you want to remove the tumor, or you want to target the biopsy to the wall and not to the center of the lesion. So it's important that the surgeon will know what to expect. So when we favor an abscess, if you see the central DWI restriction, you can use MRS, where when you see lactate, cytosolic amino acid at 0.9 ppm or acetate at 1.9 ppm, then you should think of an abscess, and you see low RCDV at the abscess wall on perfusion images. And you favor the tumor if there is no central DWI restriction, or if the DWI restriction matches the enhancement, and we'll see an example of that. Also, if you see choline in addition to lactate on MRI or on MRS, and of course high RCDV in the wall of the tumor. And those are two examples of GBM. This one has a peripheral diffusion restriction because of the high cellularity of the tumor, and the central area does not have diffusion restriction. So this is not a pattern of an abscess. And in this case, another GBM, glioblastoma multiforme, there is almost complete, the lesion is almost completely diffusion restricting, but also all the area of diffusion restriction is enhancing. I hope you can see that. So this is not a pattern of an abscess when you expect the enhancement to surround the area of diffusion restriction. And last, do you have time still? It's okay? Just 2 minutes. We can skip the...
it's up to you.
What are the other audience?
Go on.
Go on? Okay, thank you, Anna. So let's move on to the encephalitis, which is, we move from the pyogenic infection towards the viruses. And the most common sporadic encephalitis is Herpes simplex encephalitis, which is caused from reactivation of the dormant viral DNA, HSV1, usually in the trigeminal ganglion. And the age should be 1 month or older, because neonates have different type of herpes encephalitis due to exposure during labor. And this is a fulminant hemorrhagic necrotizing encephalitis. You want to make the diagnosis as soon as possible. And many times you have seizure, behavioral changes, and as I said, mortality is high, even with the appropriate antiviral treatment. On imaging, you see affinity to the limbic system, anterior medial temporal lobes, insular cortex, as in this example, subfrontal area, and cingulate gyri most commonly. The pattern is of bilateral but asymmetric involvement with sparing of the basal ganglia, as in this case, the upskirt. And you see increased T2 and gyral spreading in the cortex and subcortical white matter, and you might see enhancement. And this is the WI of the same case. We see DWI restriction and faint enhancement. And this is another case of HSV encephalitis in a child that presented with lethargy, and on CT, the almost only sign was this small hemorrhagic focus. But on MRI, a day later, we see the significant edema in the anterior temporal lobe, and the combination of hemorrhage and temporal lobe disease with edema makes the possibility of herpes encephalitis very likely, and even with appropriate treatment, we see significant damage later on. And another type of herpes encephalitis is HHV6 encephalopathy, which is seen in immunocompromised hosts, mainly post-transplantation, either stem cell transplantation or solid organ transplantation, usually 3 weeks after the transplantation. And what you see is bilateral, symmetric, medial temporal lobe disease with diffusion restriction. So this is HHV6 encephalopathy in the appropriate clinical settings. Another disease that can cause parenchymal disease is TB tuberculoma, which is the second pattern of TB involvement in the brain. And here you have small nodules enhancing in the brain with typical low T2 signal. In this case, you can also see the basal meningitis. So, take-home message. Infectious diseases are here to stay. Be familiar with them. And look carefully on the DWI. You will see the diffusion restriction in the subdural effusions. You can see the extension of the infection. And try to remember the typical disease pattern that I showed you, in order that you will be able to suggest the possibility of infection, even if clinician didn't think about it before. Thank you.